Welcome to the One Piece Implant Mentor Podcast. I'm Dr. Andrea Joy Smith, your host and your mentor. You're going to love the down-to-earth nature of my next guest. My next guest has been practicing dentistry for nearly 30 years, if not more. He practices in Berkeley, California. And the unique thing about his practice is that he actually has an office in his original family home. His dad, Dr. J.D. Saddler, practiced there as well. So he is carrying on that family legacy quite well. Dr. Saddler, welcome to the podcast.
Thank you for having us, Andrea. I appreciate that. I'm really excited about this. I always look forward to talking with you, as we always do often. And I love doing the podcasting. I think the podcasts are really different. I was telling you earlier that people who watch podcasts are unique people who want to grow, or the dentists that want to learn something different, want to take dentistry to the next level. And I find that people who follow podcasts are always going the extra level to find out something new. So it's a pleasure and an honor to be able to spend this evening with you and talk about some dentistry.
That is very, very good. I'm glad that you brought that up, because the main reason that I'm doing this podcast is because I've been doing small diameter one-piece implants for at least 15, 16 years. But most doctors that I meet have never even heard of the procedure, or they've heard some misinformation about the procedure. And so this podcast really is going to introduce doctors all over the world to the paradigm of one-piece dental implantology. It's a new concept, it's a new paradigm, but it's one that I think is very worthwhile. It can actually change your life as a practitioner, as a clinician, and it can definitely have a big impact on your life. So podcasts in general can definitely educate people, and that's why I listen to a lot of podcasts too. But this particular podcast is going to help that dentist take their knowledge of one-piece implantology and just implantology in general to the next level.
I agree. As you know, we've talked before. I've done both. I've done conventional two-piece, conventional implant, later on going back to place an abutment in and place the crown. So I've done that. But I'm also been lucky to do the one-piece implant. And I love it. And actually, there are situations where I still do both. I tend to do the one piece more than I do the conventional one, just because of the workflow. Workflow is important. And I think we need, as dentists, to understand the workflow, being able to get in and get out and make this thing work where it's going to be productive, but also it's going to be stabilized and that's going to actually work. So conventional ones were a little more intense, where you had to actually do the surgical flap and the post-op, a little more evasive. Where the one-piece implant, it's almost half the time. I found out the one-piece is kind of be the new wave going forward, because they definitely work. I mean, there are circumstances where you might want to use the conventional one, depending on how much bone or you need additional strength. You might want to go with the conventional implant. But the one-piece ones are very functional and very easy to use. I keep using the word workflow, because at the end of the day, as general dentists, we can appreciate the word workflow. We want to be able to provide a service within a reasonable time, so it's helpful to the patient, and then get compensated for it.
You mentioned the less invasive nature of the procedure. One of the things I love about this procedure is that it is less invasive. You don't have to disrupt the blood supply, and that's why the healing time is a lot faster. We're simply preparing a little pilot drill most of the time, unless we're using one of the larger ones, but we're not removing the blood supply from within the bone. We're not laying a flap to disconnect the blood supply from the bone. That makes that healing time so much better. So the less invasive nature of this procedure is definitely attractive. And do you have medically compromised patients that might not be a good candidate for that longer, more invasive process, and you find that you're able to use the one-piece implant?
Definitely. I mean, as you know, as we work on older patients, they may have different things going on. So you find that the one-piece one is a little bit easier for them, so they can tolerate it and not have the contraindications of doing a surgical flap, where you have possibility with healing time and all that. So it definitely works much better. I guess the common denominator is workflow. You can kind of get in and get out and not have to worry about the other systemic situations that may slow you down or create a potential problem.
And workflow, patient comfort, the ease of providing the service, all of those things really play into how we practice dentistry. And it affects our bottom line, of course, but it also affects that patient experience. The patient experience is the one thing that we like to control. And some of the procedures that we do, we're not able to control them as well. So when you can come up with something that's a little less invasive, a little more streamlined, and it's not going to disrupt even their lives very much. They're not going to go home with a lot of pain, a lot of healing time that needs to take place before they can actually have that conventional implant uncovered. Now, I have nothing against conventional implants. I actually restore them all the time. But the thing I like about the one-piece implants is that the restoration of them is a lot simpler, and also the whole placement of them too. And like I said, patient experience, you can't buy that. It's something that you can provide when you have a less invasive, strong procedure that they can benefit from.
One of the things I've used more common are for the stabilization of
Yes.
dentures, especially the
Mm-hmm.
lowers. That's worked out very well with those. I mean, patients are complaining all the time having to wear to fix a dent, or they can't chew because the lower or the upper is moving around. And when you can stabilize a patient's upper and lower
Mm-hmm.
prosthesis, and it's just more functional, they can enjoy different types of food, more
Mm-hmm.
food, and not have that issue with having to wear the
Yes.
adhesives or having a problem of the prosthesis moving around.
Yeah.
So it's been working very well in our practice because we definitely do a lot of upper and lower denture stabilizations in our
That's
practice.
great, because I have transformed patients from conventional dentures to the one-piece implant supported denture. And with the conventional denture with no implant support, they had a recurrent Amazon order every month for their Fixodent. And they were actually
Right.
using it. And so when they could stop ordering that Fixodent every single month and stop using it, it really is life-changing. It has a huge impact on their life. It also has the impact of them being able to enjoy their food more when they're out with company because they don't have to
Right,
worry about
exactly.
it moving around, or some people even take it out and eat without it. We have a
Exactly.
really big impact on their lives.
Especially on the maxillary one where you can actually create the horseshoe upper, it affects your
Yes.
taste buds. So those who not have to wear the full upper denture can now wear the
Uh-huh.
horseshoe and taste food, hot and cold foods. They can actually feel it on the palate of
Yeah.
their mouth and enjoy their food. So it's worked out really well. My patients love it. And it's good marketing too because the patients who are wearing dentures have friends that are wearing
Yes, they
dentures or
do.
prosthetics. Look, I got this. You should go see my dentist. Look, this is what we
Mhm.
have. And look, I can chew corn. I can do this and that. What's his number? I want to call and see him. So I've done a lot of internal
Uh-huh.
marketing just from me working on my own
Yes.
patients. Have been able to get other patients to come in and get the procedure done. So it's worked out very
Yeah,
well.
because like we said, it's definitely life changing. So speaking of that, if it's had such a great impact on your patient's life, I'm pretty sure it's had an impact on your bottom line as well.
Definitely. I shared with you before, we made the analogy of doing a class 2 filling or MOD filling on a
Right.
patient, and we only have a millimeter or 2 millimeters before we get to
Right.
that pulp. So you really know going in, making that special preparation, and you're spending 45 minutes to an hour to do that one
Right.
filling, and get compensated $300 for that. Whereas if you have a single implant, you're placing that implant, but you got 15 to 13 millimeters of room to work
Right.
with, right? Pain goes in, done, and you walk out in 35 minutes, you made
Absolutely.
$3,500.
The dichotomy is striking. But I also tell patients or other dentists, if this procedure didn't work, or if I felt that I was doing my patients a disservice, I don't care how much it could improve my bottom line. I wouldn't want to do anything that's going to harm my patients, do a disservice to my patients, and not work for a prescribed amount of time. There is no money in the world worth my reputation or for me to do something to a patient that I don't really believe in. So that is another reason I offer this procedure, because I'm confident in it. I know it's going to work. And whether I make money off of it or not, I know that I'm doing something that's eventually going to help that patient. It's going to last like any other durable medical device.
Exactly. And the patient's comfort, the patient's ability to feel comfortable about the
Yes.
procedure. When they go home, there's no pain. That's the reward there. You provided a
Yes.
service, no discomfort to the
Yes.
patient, and the patient's excited. They come in and initially they're worried about, you're going to put a screw in my bone and I'm not going to feel
Yes.
it. And they're awake and they get it done and like, my God, that was
Uh-huh.
it? Can we do
Yeah.
it again? Can we do the other side today? If I knew it was going to be that
Yes.
simple, I would have done multiple ones. Again, with it. But in 3 years, I end up owning the machine in the process. And I didn't have that lab bill.
Right.
So there's a margin there where it paid for itself. And then the fact that you buy one-piece implants, one piece, right? You buy the one, it goes in. I'm not buying the abutment. I'm not buying the healing abutment. I'm not creating a lab cost. So it all kind of made. In about 4 or 5 years, it all pays for itself.
But I'm kind of bringing up this point because a lot of times when we invest in things for our office, it takes a long time to recoup that investment sometimes. Like you said, the CEREC, 3 to 5 years, you own it, but yet you are still paying a lab bill. But with this one-piece implant protocol, the armamentarium is fairly simple. The implant itself is very inexpensive, comparatively speaking. You don't have multiple parts. And so the point I'm trying to make is that it won't take long for you to recoup those startup costs. Now, I have a CT machine in my office that costs about $100,000, but that CT is necessary for me to do my implant work.
Again, let's talk about that. I could not work without that. It creates the confidence that you need to know what you're doing, where you're going to actually place that implant. From that, you can get a good idea of the density of the bone, where to place it, where not to place it. Before, that was the difference. You do a flap, you have to look and see where the bone is and where you can put it. With the CT scan, you can look and say, oh, I can tell this has a little more dense bone, this one doesn't. If I put it at this angle here, so you can actually plant it. Before I was placing implants, I was sending them out to the oral surgeon to have him place the implants. And that's what motivated me to get into implants, because I was initially intimidated by implants. I was like, I can't do it. The insurance is not going to pay for it. I'm putting these metal pieces in people's bone. They're not going to do it. Everyone who came to my office and asked for an implant, I was referring them out. And they were getting it done. Everyone I referred out, they spent the money and got it done. I'm like, wow, I could be doing it myself. So I'm sending money away where I can put it to myself.
And you were probably thinking, oh, they're not going to invest in that. It's too expensive.
No, and they were spending the money. But this is the point. When the oral surgeon was placing the implant, they just placed them. Now that I place them with a reason, because I do the planning for it, right? So I can look at the CT scan. I'm going to put an implant here, implant there. I'm looking at the patient's occlusion. How's it going to affect the opposing? So I'm going to have the right angles, this way, that way, so I'll know how to set that up. Whereas the oral surgeon puts it in, and I get it back from the oral surgeon, I got to figure out how I'm going to restore it. And sometimes they may have it a little bit to the left, a little bit to the right, and I have to go get a custom abutment. It doesn't work. And I can have the control and have the autonomy to put it where I know it's going to actually work. And using the one-piece implant, you can really tell. And with the new software now, I can actually plan it before I place it. Because the software, it has that one-piece implant in the software where I can tell whether it's a 3.0 by 10, by 15, I can actually place that implant in the CT scan and make sure it lines up parallel, make sure the occlusion is okay before I place it. And I can determine how I'm going to be able to restore it, or if I can even restore it, because that's another thing too. Everybody can't have implants. I have people calling, I want an implant, I want an implant. I was like, implants aren't for everybody. So you got to be very selective on who you choose and what's going to work. Because some people, there's not enough bone, or they're grinders, so they have some other issues going on. And they're not a good candidate for implants. I've seen patients come in and had implants in their hand. It was supposed to be in their mouth, but they came out because it wasn't planned well.
That's a good point that you make. You're not just looking at bone to place the implant. You're evaluating the occlusion. You're evaluating the opposing occlusion. And sometimes when we send it out to the oral surgeon, as good as they are, they're looking for the most solid piece of bone to place that implant for its longevity. But then you have to restore it. And if the occlusion is not considered, if certain factors, the patient's bruxism habits and things like that are not considered, it's really difficult to restore a tooth that doesn't have the proper consideration. So having that CT, having all of those things at your disposal, it's priceless, actually.
Exactly. So there goes back to your original question about the investment, right? The CT scan, the CEREC, the single implant is an investment. But once you're able to pull it all together as a unit and works into your workflow, it pays for itself.
Great. I'm going to have to look into that CEREC. Years ago, I did buy a CEREC, but I ended up returning it because the workflow of my office is just easier for me to have all of my crowns laboratory fabricated. For me, it was the design process and having either a designated staff member to design or myself designing it. And I just felt like the way that my office flowed, it didn't afford us enough time to do that. But now that I think of it in terms of that one-piece implant, that might be a good thing to look at as well.
The CEREC has come a long
Okay.
way. The latest one has this prime scan. Believe it or not, it has artificial intelligence. There's AI in CEREC. Okay.
Wow.
It is amazing. You can take an image of a tooth or image of an implant. It will design the crown for
Okay.
you. Literally design the crown for you. It has what we call a biogenetic library of what a crown should look like, which is part of the AI part of it. And then you can look at the crown at that point. You can see where the margins are. You can see where the contacts are. So there's a little adjusting that you can do to get it fine tuned, and then it's done. It designs itself. And so my staff is doing it. One of my RDAs, she can get in there and design a crown better than I can. And she actually enjoys doing it. There's some other doctors who have done it where they've actually hired a lab person to come in and do it in the office just to get it designed. And you come in, you can confirm what you're looking for, and it works out well. So it helps that workflow again. So it's still less expensive to hire that lab person. But again, I would encourage that. Your staff can do it. And they enjoy doing it. I have one, her name is Maria. She started with me when I started with the CEREC, but she can design a crown. And what she's been able to do is train hire other dental assistants to come in. And she's trained them on how to do it.
Wow, that is great.
And they're just as good as she is. So support staff is amazing with that. So definitely with the new technology, I think it's growing further and further. It's getting more and more smart. Right.
Well, at the time when I did it, there was definitely no AI. And I felt like I had to spend too much time working on the occlusion. You know how it comes out red, then you have to do this and that. So that was the thing that sort of deterred me. I had it for a few months, and I like the idea of it. That might be something I might be doing.
Yeah, it was definitely a learning curve. I started out, there was the red cam, the blue cam, the omni cam, now it's the prime scan. So I'm fourth generation with CEREC, and they got a new one coming out in September. But the way it's done now, that AI is amazing.
That is great.
It does amazing things. So it's something you might consider. And now with Dentsply Sirona, they're actually able to design partials and dentures. So dentures are being 3D printed. So imagine 3D printing a denture with the one-piece implant design and part of that denture where it stabilizes that upper
So with
denture.
that housing, you can program the housing spot in the denture to be milled into the denture, so you don't have all of that troughing out to do.
No, it's already there. It's plug and play. You print the denture, and it already has attachments inside the 3D printed denture.
Wow, that's actually a good point, because one of the things I tell my patients right before I stabilize their denture is the implants are going to go in relatively quickly. The longest part is to retrofit your denture, because I have to make sure that it sits passively over those housings so that there's no undue pressure. So I usually have my staff retrofit the denture, but it does take a longer time to retrofit their denture than it does for me to actually place the implant. So we might be onto something with having the CEREC.
It's here. With that new 3D print, it's amazing how they're doing that. Now, the quality of that 3D print denture is being printed versus the acrylic and being,
processed in.
The process is different. It won't last as long, but the material they're using now, they're coming out with newer material. But for a provisional, you place implants, and then you give them a provisional upper or lower, and they can wear that, and that's all in one piece, and you can load it the same day, and you control the bite. The patient can actually walk out with something in their mouth.
Absolutely. One of the things that I do, I use Glidewell for it. So I'll take my iTero scanner, and the patient can still have a full mouth of teeth. I mean, granted, there's none of them that are restorable, but I'll scan that patient's mouth the way that it is. I'll record a vertical bite, and then I'll send that off to Glidewell or to my lab, and I'll ask them to make an immediate set of dentures. And what they're doing is they're printing them. So they virtually extract all the teeth, and then I'll tell them, leave me a trough because I'm going to put some implants under it. And so that's one of the things that has propelled my workflow and helped me flow a little bit faster, because now I can scan the denture without having to at least try in part of it to establish the vertical. The vertical is already established with that bite scan on the iTero. So that is one way that I am able to move my workflow along and not have to go through try-ins and wax bites and things of that nature, especially if they already have teeth, so that they'll send me back those dentures the day that I do the surgery. I take the teeth out, put the implants in, and the denture has been left with a large trough in it so that I can go ahead and do that. So for my immediate dentures, I am starting to scan those in, and they're only provisionals. I normally do a regular laboratory process denture for the final denture, where we can take time and the teeth can be individually set and the patient can choose the tooth color, and we can do all that. But for that provisional restoration for a patient that has a mouth of teeth that they're not proud of, and for us to do that for them in literally one visit, it's life-changing.
As you can imagine, that whole digital imaging is amazing. The quality of work when I was sending stuff to the lab, I do send stuff to Glidewell for my prosthesis. I've taken digital impressions and got a denture back that fit like a glove. Versus taking a conventional and algae impression is always that discrepancy, right?
Always.
Digital impression, night and day. It makes a big difference. Turnaround time is faster. You send a digital X-ray, it goes in 20 seconds. They're working on it in 30 seconds. They can deliver that next day. Whereas you take the mold, you got to take the mold, pour it up, send it to the lab. Hope it doesn't change shape, and it finally, you know what I mean? So it works out
really well. Good. Well, I'm going to circle back around to this one-piece implant, because one of the things you brought up earlier is the fact that you do single tooth replacement, and particularly that Milo implant, the ones that are supplied in the 3.0 and the 3.75 millimeter diameters. Those implants in some ways function like conventionals, but you use the same technique of achieving that desired 30 Newton centimeters torque and being able to place a tooth on that implant the same day. That alone is very impactful. And the beauty of this implant, it has so many wonderful features. The Osteon coating that helps with osseointegration. The fact that with the smaller diameter ones, the 2.0 and the 2.5, you're just preparing a small osteotomy. You're not disrupting the blood supply. And then for those larger implants, you mentioned earlier, you might have patients with a little bit more bone. You can use that 3.75 implant in the place of a conventional implant and have that patient up and running with the tooth in the same day. That is definitely life-changing.
No doubt. No bleeding. I mean, this post-op is minimal. Patients waiting for this pain and waiting for all this discomfort.
It's not there. It's not there. Well, Phil, I certainly have enjoyed this conversation with you. We've touched on a lot of different things, the CEREC, the CT machine, the implant. Actually, when you put it all together, and especially in your office, you've kind of put together this dream team of technology and service that actually allows you to give that patient the best service that's available in the world.
My patients like it. I mean, I'm kind of a tech person, and my patients walk my office and go, God, what have you got now, Doc? You have all these toys, you got all this technology in your office. And that makes me feel like, well, if he has the technology, he's into technology. He's into providing the best care for his patients. And people appreciate that I do that. And that's the reputation I have in the community, especially among my patients. Like, I go to Dr. Saddler because he's on top of all the latest technology. He provide the best care for the patients. And I'm doing it. They see me doing it. They see all the technology, and they're impressed. Like, okay, this is my guy, and they provide quality work. That's a win-win.
Another good point to make about not only being into technology, but you're basically into advanced procedures. Because if you think about it, most surgeries, open heart surgery is not done very frequently. Knee surgery is all done arthroscopically. They're using robots and those kind of things. This one-piece implant sort of takes a forward step in surgery, and it's less invasive nature.
No doubt. Because people get one-day hip replacements and the knee replacements. And I mean, it's one day. They're doing it real simple. They're using technology. I'm sure with the hip replacements, they're using current technology, and it works out well for getting hip surgery and walking the same day. They literally walk. It's the same day procedure. They're walking out of the hospital or walking on that leg.
In fact, they want them up walking that same day. I actually had a colleague of mine who had both hips replaced, and he said the next day they had him walking on both hips. So I don't know how you quite do a knee replacement minimum through a little tiny incision, but just the less invasive nature of all surgeries across the board, it puts the one-piece implant on par with that. And so that's an advance in technology. That's an advance in treatment. In medicine, it's like leaps like 10 steps ahead, just being able to do something so simple and less invasive. Any advice to any new doctor listening to this podcast or hearing about one-piece implants for the very first time, and they might have a little bit of trepidation or hesitancy? What advice would you give them? And why would you tell them it's a good reason to start doing this procedure?
It's so easy to do. It's very intimidating when you think
Yeah.
about it, but take some courses or talk to some people about it. But and even that, I mean, just do
Hmm.
it. It's not that bad. You know what I mean? I mean, I was very intimidated initially when I
Yeah.
went in. I mean, I actually did it, and I found out it was easier than doing a filling. It's not that bad. But you don't know what you don't
That's
know.
right.
But until you actually do it in any procedure, I'm sure even when you're in dental
Hmm.
school, giving that first injection, oh my
Yes.
God, you're nervous, right? And now you get to the point where you just do it. It's a second nature. Boom,
Yeah.
you do it. In my office, we do implants on Fridays
Uh-huh.
only, and we're booked for the next 3 or 4 months. Well, one guy would tell me that you have to be dedicated to it. Like I do implants on Fridays, so our mindset is all about
Yes.
surgery on Fridays. So,
That's smart.
but getting yourself organized, like getting a
Yes.
workflow again, it's not bad. So I would tell anyone, encourage anybody to definitely do it. Once you do 2 or 3 of them, you'll see how it's not that
Right.
bad. You're providing a great service for the
Right.
patient, and it just works out well for
And
you.
your patients will literally love you. I mean, if they've been fighting with a denture or had some missing tooth that they were told because it's a lateral incisor that's missing, they don't have enough bone, they need a bone graft. I always tell patients, look, I have an implant that'll fit your bone rather than me having to expand and manipulate your bone to fit my implant. And so that alone just gives us a good reason to try it because these patients are in our office. We see them every single day. We're referring them out. They much rather come to you than to go to see a dentist that they've never met before. And they're just there for one procedure and then it's back to you anyway. So that's a good reason to start doing it is because you can keep your patients in house. And that alone makes your patients happier. Every time I refer out a root canal, my patients go, well, doctor, you did a root canal on me before. I say, yeah, but you know what? I don't do as many root canals anymore. All the molars I refer out. I still will do an anterior or bicuspid, but the molars I do refer out. But if those patients could stay in my office for the more complicated procedures that they needed, that would be priceless.
Exactly. That's part of your marketing, right? That's what patients want. They don't want to travel. They're with you for a
That's
reason.
right.
They feel
That's
comfortable
right.
with you. You don't want to have to go somewhere else and get a procedure done because they may not meet somebody like
Exactly.
you.
They
Or may
trust
have a bad.
you.
They trust you, so they can keep it in
Hmm.
house. It works out better.
Yeah.
So implants, they're not going anywhere. That's the new word
That's
now.
right.
It was a clear
Yeah.
choice. They do all the commercials, and I like it. Let Clear Choice do the commercials because what happens is it brings us
It
patients, right?
does.
They're doing the commercials. They're paying for the
Yes.
marketing, but people are seeing it. So the first thing they're going to do, well, let me call my dentist who
That's
I
right.
trust and do that procedure I just saw
Yeah.
on
That's
TV.
exactly what happens.
So, oh, I can go to my own dentist and get that done. That's where I want to go.
Yes.
Versus going somewhere you don't know who the person
Yes.
is, and that's the biggest
Yeah.
fear. 80%, 90% of our patients don't really want to
Yeah.
see us, right? They like us, but going to the dentist is not necessarily
Exactly.
a lot of fun. But if they can find somewhere where they can go and feel comfortable with somebody they're
Uh-huh.
working with, it works out well. So you want to be
That's
prepared.
right.
You want to be able to have the
Mhm.
technology. You want to have the know-how to be able to do the things that people are
Yeah.
looking for and provide that
Well,
service
I
for them.
second that. Hey, you've given the new doctor that's thinking about doing this procedure a lot of good reasons to do it and keeping
Yeah.
patients in house, having them continue to trust you. And that's the win win right there. So thank you for that advice. And I'm hoping doctors that are listening to this podcast will be able to find something in Dr. Sadler's story that will propel you into doing this procedure. I want to say come to the edge and do one piece implants because your patients will love you. You will appreciate the difference that it can make on your bottom line as well. Thank you so much for joining us.
Definitely.
And Dr. Sadler, again, thank you for joining me on this podcast today.
Thank you, Dr. Smith. Appreciate it, and look forward to seeing you spending time.
Absolutely.
Look forward to seeing you spending time with us again.
Absolutely. Talk to you soon.